Yes.
Yeah, okay, right. So,
Doctor, we are live now.
yeah, okay. So, welcome to this webinar on core concepts in ocular trauma from triage to treatment. At the outset, I'm extremely privileged and honored to have all of you on board here. I think trauma forms a very important aspect of ophthalmology, and I think all of us have to know how to treat from the beginning, from triage, and also to manage the more important complications of trauma. And we have with us excellent faculty as well as discussants who are going to take us through the different aspects of trauma, right from the cornea to the retina. More importantly, we have Dr. Nirmal Fredericks, who's going to give us a very nice talk on the medical legal aspects of trauma, how to handle the patients, because this is something which we face from pediatric age group to the elderly, and it's very important to counsel them properly so that we don't get into any medical legal complications. So with these few words, I welcome you all once again and for taking your time off to be part of this webinar. And looking forward to a very enriching webinar. So before I go on, I'd like to introduce my panel. Dr. Mohan Rajan. He is the chairman of Rajan Eye Care Hospital, also the current vice president. And he has several publications. He has done numerous named orations and won several awards for his videos and his talks. And I welcome him on board and looking forward to a good interactive session with him. And then we go on to Dr. Nirmal Fredericks. Unfortunately, I don't have any of the PowerPoint that I prepared because I had to change the computer. So I'm just going to speak off the record. So Dr. Nirmal Frederick, I think he's the chairman of Dr. Nirmal's Eye Clinic. And more importantly, he was a former president of the Tamil Nadu Ophthalmic Association. And he's also been very actively involved in the Ocular Trauma Society, as well as in NABH, Tamram Ophthalmic Society. And also he's on the advisory board for several IMA chapters and so on. He has a list of accomplishments. And we are very happy to have him here because he's one of those people who can give us an entirely new view about how to handle trauma. And then we'll go on to the panelist, Dr. Radhika Natarajan. She is the head of cornea and Shakanetralia. And she's had several publications and she's a mentor to so many students. My daughter being one of them, Dr. Madhuvanti, who's going to speak and she's going to be the discussant. And she has several accolades, a very pragmatic and a very down-to-earth person. So I welcome you, Dr. Radhika. So next we go on to Dr. Devendra Maheshwari. He's a consultant at Aravind Eye Hospital and he's a glaucoma consultant. Then Dr. Manavi Sindal, she's also from Aravind Eye Hospital. She's been trained in vitreoretinal services at Shankar Netralia. She's not only a good clinician, she's got excellent surgical credentials. She's had several publications and we are very happy to have her with us. Dr. Bhaskar, formerly from Shankar Netralia, who served in the ocular surface, is now the director at Code Eye Care. And probably is one of those very few people who is an authority on ocular surface in the entire world. And not only that, he also has an interest in pediatric corneal problems as well as in refractive surgery. And last but not the least, we're going to come to Dr. Sendil Nathan, who's the director of Ramana Eye Care and also a consultant at Rajan Eye Care Hospital. He was also trained at Shankar Netralia and did a short stint at the Leicester Eye Care at UK. And he is interested in orbital trauma, aesthetics, and is probably one of the very good surgeons in oculoplasty. I hope I've not left anyone behind.
Madam Dr. Shirish Kumar.
Dr. Shirish, yeah. I forgot, I don't have the slides with me. So Dr. Shirish, actually, I've known him for more than 20 years and is one of the finest corneal surgeons. I've seen some of his surgeries being referred to us and to follow up, and I'm really happy to have him. And everybody knows him that he is one of the pillars of Eye Foundation at Coimbatore. We're also very happy to have Dr. Shirish Kumar with us. for the discussion. And I'm extremely happy to introduce this very august panel. And now we'll go on to the first keynote address by Dr. Nirmal Frederick. Over to you, Dr. Nirmal.
Manavi Sinthal, you introduced, no?
Yeah.
Okay.
Thank you, Madam. Thank you, President and Secretary of TNOA for a kind invite. Regards to the AWS Vice President.
Thank you, boss.
Thank you, Mohan Boss, for this opportunity and the entire faculty team. It's indeed a pleasure to be part of this event. And the moment Dr. Sujata has taken over, there has never been a dull moment in TNOA. There's been a continuous array of programs. I'm happy to be part of one such programs. So the Ocular Trauma Society has been doing a wonderful job. I'm happy to be part of that. And from the society, I bring regards to the TNOA team. And thank you for considering this important program. And as we advocate for ophthalmic trauma 360-degree, prevention is one of the important aspects. And of course, medical legal aspect is one of the key factors for prevention of injury, not only to the patients, but also to the practitioners. So these are my credentials and no financial interest. So a young worker rushes in at 10 p.m. with a penetrating injury, and his anxious family surrounds you. The clock is ticking. If you're also thinking about the medical legal register, this lecture or this talk may not be for you, because we all know that every trauma case is potentially a medical legal case. So the eye surgeon has to walk a tightrope. So whether to start the treatment without going through the paperwork, is my slide visible?
Yeah, next here it is here.
Yeah. Okay. So balancing the art of healing with the science of law. So global burden of ocular trauma, once called the neglected disorder. So medical legal aspect is not something new that we are tackling. So if you see the article published on August 11, 1900, injuries to the eye and in their medical legal aspect published in Egypt. And many such studies keep occurring, not only in the Mediterranean countries, but all across the world. So we need to understand medical legal aspects before treating the trauma patients. And since the time is short, I thought I'll just cover 8 points on saving eyes and sight to saving the eye care providers from trauma. So the 8 commandments start with having a policy for trauma care. This is very, very important. So thou shalt have a policy for trauma care. It's mandatory for all doctors as well as hospitals. So we need to have certain systems and process before we take emergency services. It is mandatory to care for emergency patients as per our Medical Council Ethics Act. And we also need to have certain system and processes for providing emergency care, and also give care, not only give first aid and care, but also appropriate referral policy we need to have, admission as well as discharge to home or transfer to another facility. The important point is the register. So if it's not documented, it did not happen. This is true to all medical legal cases. And we need to use this MLC forms in triplicate. This is a legal requirement. You need to document the time of admission clearly and record your designation. And please avoid abbreviations and overwriting, because the non-medical people, the advocates and legal people may not be knowing the abbreviations. And it's better to take some photographs or draw certain sketches so that you can recollect, as well as it makes the people understand. So never make backdated entries. And if you are correcting or doing any changes, authenticate all changes. And meticulous examination, needless to say, is very, very important in when you are documenting in the accident register. So mainly the patient demographics, the history of the injury, the visual parameters, the main examination findings, and the essential investigations you've done at the casualty or AR is very, very important. So it's meticulous examination really saves you from many of the troubles later. And the reports must be in duplicate or triplicate. This is a legal requirement. And medical legal documents should be stored or safeguarded. So never use terms like about or approximately. So use accurate terminology, because in medical reporting, it is reading between the lines is also important. Particularly the lawyers are very fond of this. So the second point is you should assess the risk. Triage and risk assessment is very important. It's not only ophthalmic assessment, but also the general risk. So we will be having a lot of high-risk patient groups with trauma. So you need to check their vital signs, BP, blood sugar. So you can't escape general assessment here. And also be particular about the high-risk patient groups, particularly patients with polytrauma and elderly patients with multiple comorbidities, and patients referred from other clinics seeking second or third opinions. It's important you look for abnormal vital signs and also document the vital signs in the case record. So a patient can be sick with normal vital signs, so always reassess if signs become deranged. Very often we see this gap in general assessment in eye hospitals. The third point is follow standard operating procedures and protocols. So for the examination, go methodically from anterior to posterior. Use a standard classification like BETS classification. Use the standard terminology and be systematic so that you don't miss any points. And you can also use the ocular trauma score for prognostication. The trauma care continuum is very, very important. History, and look for the red flags, do the assessment. And if you are doing any imaging or intervention, do a reassessment, run the diagnosis, and important is communicate this to the patient and their attenders. The fourth point is investigate appropriately. Very often there are two important points in investigation. One is appropriate investigation missed or done after the procedure or surgery, or late referral. So you need to have high index of suspicion for blunt and penetrating injuries, diabetic patients, and multiple surgeries in the same sittings. So better to do essential diagnostic investigations before the surgery than repenting later, particularly B-scan or CT orbit for intraocular foreign body. So right investigation at the right time. And important is many of us have less facilities, and if it needed, you need to refer at the right time. You need to have high index of suspicion in all these cases so that there is no delay in diagnosis. The fifth point is, so in ocular trauma management, you need to perform essential tests before repair or reconstruction, give appropriate advice, counseling, and get informed consent. Maintain aseptic precaution in the OT. Many times it is done in the side room or aseptic OTs, septic OTs. So it's important you give the same care and facility to trauma patients. And ask about drug sensitivity and systemic disease. We know that it is an emergency, but it's important we ask and document the drug sensitivity and systemic disorders, and rule out any pre-existing ocular pathology like chronic dacryocystitis or retinal disease before the surgery. So document chronologically and ensure the trauma care continuum is followed as a system and process. The fifth point is the 5 C's. So ocular trauma happens suddenly. So the emotion associated with vision loss or eye injury is ranges from depression to acceleration. So important that we are compassionate and committed to give the utmost correct information to the patient and their attenders. So communication, counseling is very, very important. So counseling, use lay language, explain the prognosis, and document the prognosis, and also provide emergency access numbers. Particularly, most of the eye hospitals are daycare centers. So you need to provide emergency care as well as provide emergency access to other hospitals. Inform expected expenses upfront. Cost is one of the most common medical legal issues that happens. Consent is very, very important if it is multiple procedure. take multiple consent, and have a complaint redressal mechanism which solves most of the problem before it goes to the court. So learning the soft skill of breaking bad news is mandatory, not optional in trauma care. So most successful doctors are those who communicate or break the bad news very well. The sixth point is assessing the disability. Many of us are comfortable with treating the patients, but we also need to continue the care beyond caring for the injury or emergency. So we need to, once we give the care, there might be some disability. So we need to assess the disability and help in getting the compensation. So basically, assessing disability happens in two fronts: for deciding the compensation, and also our role extends beyond treatment, that is rehabilitations. We need to determine the percentage of disability. For one eye, if there's a eye loss or vision loss, it is 40%. So issue certificate appropriately with all the proper documentation, and if may be needed to testify in the court for insurance or the disability benefits. The seventh point is medical records in trauma care. You need to safeguard all the medical records and the investigation thoroughly. And important, ensure that all the important points like vision, the investigation and imaging, the chronological examination points, and the reaction, particularly in post-trauma endophthalmitis, you need to monitor all those things. Details of the iris, and if there is IOL present, all those things have to be documented. Right, so complete records must include, so before you send the records to medical records department, ensure it is in chronological order, ensure imaging and lab reports are available. If the procedure has been done, operation notes, whether legible, detailed, and timely, and if it is transferred to other units, a discharge summary and rehabilitation. So you need to maintain these records for, if it is an outpatient case, for 3 years, and if it is a procedure or inpatient case, for 6+ years, or if it goes to the court, until the case is resolved in the highest court of law. So good documents help your case, and poor document help the plaintiff case. These are the important statutory documentation you need to safeguard in your medical records room. The sixth point is, so very often we are not used to the court rules. So we may need be called as expert witness or as part of the negligence case. So our role is to require certificate to court indicating amount of loss, and also the compensation requirement will be calculated based on our certificate. And whenever you give wound certificate, so mention it as simple or grievous. And if fracture is suspected, attach the report of CT scan or MRI or whatever it is. And if it is by assault, it may be part of the criminal proceedings. So you may need to go to the court. So understand the court rules. So the disability certificate and compensation documents. And if it is assault case, you need to give a wound certificate. An entire case record with your sign may be summoned. You need to submit in the appropriate court. The last but the most difficult aspect is when you receive a negligence notice for treating a trauma case. That is the most unfortunate part, but you need to stay calm, prepare defense with references, engage a good medical legal consultant, have a professional indemnity form. But important is, don't panic and reply within stipulated time with all references. So this is the overview of the medical legal issues associated with trauma. So take due cognizance and reply in time, and produce affidavit of colleague, give good references. And these are the 8 commandments at a glance. So never backdate entries, check the vitals, identify high-risk patients, and communication is very, very important. Learn to assess the disability and maintain the records, understand court rules. So this is a summing up of from the review article myself and Murli Ariga have wrote in the TJOSR. And so the 9 R's with reference to medical legal point is, you need to have a good rapport with the patient and the family, have a good follow-up, and have a rational treatment. So plan the treatment effectively, and complete record is essential. And the 4th point is very, very important: remarks So don't make any comments on other professionals. They may be come to you for fourth or fifth opinion, and they may be recording whatever you say. So prescription, appropriate medical indication, particularly if you are using antibiotics, use the antibiotics appropriately. The sixth one is things speaks for itself. How you examine the patient, how you communicate with the patient, and how you follow up is very, very important, because those things speak for itself. And have a concern for the patient and family, and results don't over promise, and always under promise and give good results. And it always has to be shared decision making. So in ophthalmic trauma, our mission is fourfold: repair the damage, restore the function, rehabilitate the patient, be with the patient till they are rehabilitated, and prevent further injuries as well as future injuries. The prevention is very, very important in ocular trauma. If you are preventing, we are saving one person from a huge economic and being a socio-economic burden. And more importantly, preventing and following these rules are important to to safeguard our practice. So the best way to deal with medical legal problems is to prevent them. For that, we need to upskill we need to improve our skills with our abilities and have knowledge about the medical legal aspects of trauma care. A doctor who treats with compassion, documents with precision, and communicates with clarity, so that doctor builds a fortress no lawsuit can breach. So thank you all so much. Thank you for the invitation, President. May your hands heal and may your records protect you.
Thank you. Thank you. That was wonderful, Dr. Nirmal. Wonderful. Any comments from
I
Dr.
think, can I make a comment?
Yes, yes.
Nirmal, I think it's important that you start this webinar with your lecture, because it's very, whatever points or pearls you are given, the 8 or 9 pearls, whatever you are given, is absolutely necessary for all of us. And all these are not given in the textbooks. Only Nirmal Frederick can do it. So if you want that documentation, I need to do the counseling, you need to do the communication, how to document it, and how to explain the prognosis to the patient, how to know the medico-legal aspects of everything. I think Nirmal has done it all, and he has, it was really a comprehensive talk, I would say. And my suggestion is, Nirmal, because everybody neglects ocular trauma generally, because it is sidelined, it is given to the most junior person in any hospital for that matter. So I think
Yes.
we should give importance, and we have been discussing that in the OTSI and the APOTS meetings as well. You know that. So I think we should give importance to the ocular trauma, because the ocular trauma, the results of ocular trauma management can be far more serious implications than any other disease for that matter. So I think it's very important. I think it's really a fantastic talk, I would say. Yeah.
Madam,
Thanks.
can I add a point?
Yeah,
Yes.
yeah, please.
So normally for a keynote address, there are no queries or comments, but Nirmal is a very good dear friend, and he is an authority of numeric pulse. The 7, 10, 5, every point is important. I just want to give one experience where I treated a bomb blast case, and it was a real bomb blast case during one of the peak times. And when we went to the court, the judge and the opponent lawyer wanted to know whether it was really bomb blast or whether it would be a bomb inside. There was a intraorbital foreign body. Corneal tear I had repaired. So without seeing the foreign body, it is difficult to say. We had referred to a higher center. So there, most important is whatever is taken out as a foreign body in medical legal cases should be preserved. So they did preserve. So preserving the foreign bodies are equally important in the court of law. So that was a very long case and it went on for a quite long time. So that was the way it was there. Thank you so much, Nirmal, and thank you, madam.
Thank you,
Can I
Chandru.
ask a
That
question
is
if we
called
have
as
time?
material evidence. So
Hmm.
you need to preserve all the material evidence, even the foreign bodies as well as the records. So everything speaks and it has to be numbered and presented to the court.
I think
Yeah.
Quick, this thing, Preeti,
Yeah,
please.
one quick thing is like in the MLC register, sir, it is usually for acute trauma, all the questions that are framed. So when we see a secondary reconstruction, when you see a late trauma patient has already been operated, how do you make an MLC register for that? Because we had a query from NABH for that, but we usually document all the things on EMR, but is there any MLC form for that?
Yes, there is no separate form. You can use the existing form and add additional sheets. So this called as care continuum. So you are only part of the secondary and tertiary care. So you need to take over the case from the primary physician or hospital and record whatever they've given in the discharge summary. If possible, try to get the original AR entry copy and attach the copy of that.
Okay.
Or the treating doctor has to give a wound certificate. You can attach the wound certificate. From then you can put your investigations or examination points, and that will continue as the AR entry.
I'll just add a point to Nirmal, which is very, very relevant. Everybody thinks once the air entry is made in another hospital, there is no need for us to make. So the idea of an air entry is when the patient comes to us from wherever or whatever time limit it had been, it is what finding we see him first. The doctor seeing first, maybe seeing after a day or two or even a week. This entry will be the first entry by the doctor who's seen first in the hospital, and based on this only we will give it, and furthermore it will go to the specialist. Even if it is seen elsewhere, AR entry and the retention policy of MLCs are much different from that of regular cases. So it is mandatory to make an AR. Some of the suspicious cases also we need to make. So this is one point which we keep on telling our people, that even if it is made elsewhere, you have to make. Thank you, sir. Thank you, Nirmal.
Yeah, it's a very important point. You're right.
One more point is always write the history as from the patient or from the attender, alleged history of trauma or assault or how it happened in the patient's own language. Because in the court of law, they will change, the witnesses will change the thing, and they say doctor has written in their own way. So there are 2-3 cases we are managing and helping the doctors like that. So always write verbatim, whatever the patient says, write in their entry.
So this was a major NC. We do all cases audit, madam. So I included the word alleged in the typed material itself, so that it becomes routine, so nobody misses on it. Thank you, madam.
Thanks a lot. Thank you, Nirmal. Despite your busy schedule, I know you are traveling to Karaikudi, but you had time for us. That shows your love
Thanks a
and
lot.
affection, your commitment. Yeah.
Thank you, sir. And so thankfully, there's no sound here, or no roadside noise. So we just escaped from the wilderness. So thank you, President. I'll be with the.
Thank you, Dr. Ranga. Shall we move on?
Yes. Shall I introduce Dr. Madhuvanti?
Yes.
I think we will go on to the first speaker, none other than Dr. Madhuvanti Mohan, who is currently a cornea consultant at Rajan Eye Care and with an interest in keratoplasty and ocular surface disorders as well. She did her MS ophthalmology from D.Y. Patil Medical College, Pune, and then subsequently cornea fellowship from Shankar Nethralaya. She is very much interested in cornea, refractive, and ocular surface as well. And she's going to give us a talk on corneoscleral tear repairs principles. Over to Dr. Madhuvanti. Please share your slides.
Hi, good evening, everyone. Are my slides visible?
Yeah,
Yes.
they're visible.
Yeah. So I'll start. Today I'm going to be talking about the principles of corneal tear repair. So first thing we want to do is distinguish between penetrating and perforating injuries. We all know penetrating injuries, they breach the outer corneal layers, but they are contained within the corneal tissue itself. Whereas perforating injuries, they actually cause full thickness corneal damage. Why is this important?
Madhu?
Hello?
Put slideshow.
Oh, sorry, one second.
Naldo, little slow.
Yeah. Okay.
Yeah. So why is this important is so that in perforating injuries, there is a chance for the infection to enter the eye. So before we start assessment of the wound, we want to do a quick visual acuity assessment because that lets us know how bad the injury is. After which we first on the slit lamp, we see the extent of the wound, the depth, the length and breadth of the wound, whether it is extending onto the sclera, if there is any uveal tissue incarceration, or if there is hyphema in the anterior chamber, any lens matter in the anterior chamber, which tells us that the anterior capsule has been breached, or any vitreous in the anterior chamber. And also look for a presence of any foreign bodies or infiltrates, which will tell us about the potential of infection. And it's also good to do a CDLS in cases where you're not very sure if the wound is full thickness or not, and that will give us an idea about what to do further. So to prepare the patient, we explain about the visual prognosis, complications, need for other surgeries or future surgeries. To both the patient as well as the attender, obtain a written consent from the patient, give them a tetanus prophylaxis, and once all this is done, put the patient on a rigid eye shield, and ask the patient to refrain from any activities that involve straining. In cases where you suspect intraocular foreign bodies, it is better to do a CT scan or an X-ray, and give a systemic antibiotic prophylaxis. Usually we give intravenous. In these cases, general anesthesia is usually preferred because we want to prevent upthrust of the patient. So surgical goals include restoration of the normal corneal contour. And we want this because we want the normal cornea to maintain its original shape, or the shape prior to trauma. And this will also reduce the astigmatism as well as minimize the scarring postoperatively. And at the end of the procedure, always make sure that the wound is watertight. So different types of tears that we can see. One example is a linear tear. So we always start suturing at the limbus. Why is it so? Is because the palisades of Vogt will give us an anatomical landmark, and after which the rest of the tear can be sutured in halves. So ideally, the tear is there, you start at the limbus and then do 50% of the tear, and then that becomes 2 tears. So every time you suture, the tear becomes 50%. Similarly, curvilinear tear, you suture in such a way that you maintain the corneal contour as stated earlier. So which means shorter sutures in the center and longer ones at the periphery. So this is an example of a linear tear, which was because of a knife wound. So in stellate tests, what we want to do is, for example, in these 5 arms of the tear that you see, you treat each arm as a separate tear. You suture each arm separately, and then the apex is sutured with a circumlinear suture. In some cases, the fish mouthing of the tear can still happen. In those cases, we can even put glue and BCL to maintain the anterior chamber. Similarly, in tripartite tears, what we do is known as the star-shaped tear, which will also prevent fish mouthing in these cases. So ideally, suture should be 90% of the depth. We want it to be approximately 1 mm on either side of the corneal tissue. It is important that we don't take too deep a suture because this will act as a conduit for the microbes to invade into the cornea, and also make sure it is not too shallow because that can cause corneal undermining or overriding. This is an example of a tripartite tear where first we enter the AC, remove the or release the iris from the area of the tear, and then each tear is sutured, and at the end of the procedure, we just stain with fluorescein just to see if the suture is watertight. Similarly, this is a curvilinear tear. The same principles can be used in every different type of tear. So again, we enter the AC, remove the iris from the area of the tear, and ideally, it is better to suture under an air bubble because then we don't have this one to go ahead and remove the visco later. And at the end of the procedure, you suture the tear as shown here. So what are compression zones? So each tear forms a rhomboid shape, which is shown here. And the zone within which this suture is there is what is known as the zone of compression. Now, ideally, the zone of compression needs to slightly overlap each other. So each suture, the zone of compression needs to slightly overlap as shown here. If it is too large, it can lead to a leak. And if it is too close by, then it can also cause a lot of scarring. So what is Rousey-Hayes technique? This is something which we have already discussed earlier. So this technique helps in maintaining the normal corneal contour. So we start with, when we start with a tear such as this, longer sutures are there at the periphery and shorter sutures at the center. And this helps to maintain the normal corneal contour. What do we do in those cases where there is some loss of corneal tissue? If it is a small area of a loss, either we suture it, put a small suture, or if sometimes we can even manage with cyanoacrylate glue and BCL. But in larger areas of loss, it's better to go ahead with a tectonic graft, either lamellar or full thickness, depending on how that area is. But treat it as a small patch graft or a tectonic PK, so that you can provide tissue to the deficient area. So coming to scleral tear, I usually in scleral tears, this is just to add on to some of the this one along with a corneal tear. So in tears which include the sclera, we can either use 8090 nylon, and in lot of cases we can even use 80 vicryl. So again, always start with the limbus because we want the anatomical landmark to be present, after which we go ahead with the scleral tear. In case if there is a corneal tear involved, we can do that first, and after which we come to the sclera. So what we do basically is dissect the conjunctiva over the area of the presumed wound and keep dissecting and keep suturing. And as we go further posterior, you keep dissecting the conjunctiva. We go as much as possible till it is possible for the surgeon to view, and that needs to be sutured. So in many cases, we know that there can be uveal tissue incarceration. So in cases of uveal tissue incarceration, two things can be done. If it is a recent tear or an acute tear, what you can do is you can reposit the iris back and then suture the area of the tear. We have to make sure that there are no strands of the iris at the area of the tear, so that they don't get caught in the area of the tear. But in those cases where you can see that the iris tissue is macerated, or it's you can even feel like there's some kind of infected iris tissue, it is better we abscise those that area of iris tissue and then continue the tear as shown here. So what do we do when there is a traumatic cataract along with an open globe? Yeah, so in this case, so we first started with the suturing of the tear because we want the globe to be formed when we're doing a cataract. So when do we do cataract at the same sitting and when do we not do it? So in cases where there is an anterior capsule rupture or there is a significant cataract like shown here and there is a foreign body here, it is better to do cataract at the same sitting. But in those cases where there is a localized lens opacity, it is you can even wait for at a later date, wait for the inflammation to settle down, and so that even IOL power calculation can be easier. So this is an example of a patient with corneal tear with traumatic cataract. So in corneal tear with endophthalmitis, again, in these cases, we have to suspect an intraocular foreign body. So it is always better to get an imaging done, such as a CT scan, to know if there is something inside the vitreous or inside the sitting on the retina which is causing this intense reaction. So in this case, we as a corneal surgeon, yes, we suture the repair, but we do need help from our retina colleagues because they would give a good thorough wash with intravitreal antibiotics and a combined vitrectomy with the tear repair. So post-operatively, we want to start the patient on topical antibiotics and corticosteroids to tamp down the inflammation. So on first post-op day, we see the patient on slit lamp. What we want to look for is the integrity of the wound that has been sutured. See that the AC has been formed. You can do a Seedles to see that there is no leak. We can also make sure that the sutures are buried, which is very important because that's going to cause irritation for the patient later. And finally, we can see what is there in the AC. Is there any hyphema in the AC, or is there any lens matter or vitreous in the AC? It is ideal to remove the sutures maybe 6 weeks post-operatively, but in pediatric cases, maybe slightly earlier because they loosen very quickly. So to summarize, perform an early repair that is ideally within 24 hours. That is, if the patient presents to you acutely. Assess other injuries in the eye. Check for other intraocular injuries, for example, a lens touch. Tissue handling has to be minimal. Try to maintain the normal corneal contour while suturing. Make sure that the depth of the suturing is around 90% on either side of the tissue. Make sure that you bury the knots away from the visual axis. Try to minimize astigmatism by maintaining the corneal contour and by using the different length of sutures at different parts of the cornea. And finally, make sure that you follow up the patient frequently and so that we can do a suture removal 6 to 8 weeks later. Thank you.
Dr. Radhika, the floor is yours.
Yeah, so that was a very lovely presentation, Madhuvanti. I'm proud of the way that you consolidated your learning and, implemented it and, taken forward whatever you've learned to clinical and surgical practice. So that was very nice. I think you discussed everything from a small tear to a complicated endophthalmitis. You can close your presentation, Madhu.
Okay.
Close.
So the few points that I wanted to add, where there weren't too many left to add, is first of all, when the patient comes, I think Dr. Nirmal very clearly said about the preliminary preparations that we have to do. This is very important. We should not jump into the problem itself as we would do for any other, a corneal problem. And it's absolutely important to avoid topical eye drops in an open eye, because the iris acts like a sponge over there, and most of these medications are not meant to go into the eye. So, as important as it is to, avoid straining and coughing and all that, it's also important that nothing gets inside the eye. So topicals better not to use. And a Siedel's test will tell you whether it is a lamellar or a full thickness tear. Most of the time, lamellars can be managed conservatively, except in a couple of situations. So that is something that you probably didn't deal with. So one instance would be when the flap is displaced. So from the knowledge of LASIK, we know that the flap depends on the bed for its nutrition. So if it is displaced, then it becomes necrotic. So small lamellar tears also, if it is lifted from the bed, you want to do a repair. Make sure that you de-epithelize first or wash the epithelium to prevent an ingrowth. Second is in children. At that time, it may be in place, but you cannot trust the child not to rub the eye even with a BCL in place. Monitoring is difficult in children. So in small children, lamellars can be sutured. Otherwise, they can be, waited and washed. You made a very important point that however distorted or macerated the cornea may be, it is extremely important to put back the jigsaw. Don't resort to the temptation of excising hanging tissue, because suturing becomes very difficult and it produces intractable astigmatism postoperatively. So conserve every single bit of cornea without the tendency to excise it. Couple of other surgical tips would be best not to hold the wound edge. We're normally, as corneal surgeons, used to, holding the wound and suturing in incised wounds. But these edges are not the same. They're ragged, they may be infected, they may be foreign body. So it's best to hold at the limbus or, elsewhere for support at the time of suturing corneal tears. And each suture, many times the fellows will ask us, ma'am, how many sutures to put in this wound? There's no count. Basically, the count is that each suture holds as much as its length. So if you're going to put longer bites, you need fewer sutures, and you keep the zone of compression in mind that some overlap should be there. So if you're putting shorter sutures, then you need more sutures. So keep the length of the suture as an index as to, how many sutures should be put. And always try and make a separate side port. It's very tempting to go in through the wound to wash out that cortex when the lens is ruptured. So that's not to be done. Always use a separate side port after securing the main wound. And in a stellate tear, the purse string comes first, Madhuvanti. You always put the purse string first. Once you put the purse string, what happens is the wound gets segmented into multiple linear wounds, like you said. Then you treat each one as a linear wound and proceed with the suturing. Yes, glue can be used in case of fish mouthing, but two precautions. One is don't over tighten if you see, closure is not happening. Over tightening produces a contradictory effect. The previous suture loosens. So optimal suturing is required. What we should not do is to place a blob of glue. Then it entangles in the sutures and it produces a counterproductive effect. So thin layer of glue to seal the fish mouthing is enough. You beautifully talked about iris management. Older teaching was that you take off the iris. It's not like that. However old the injury is, if it is fresh iris, you can keep. Only wash is toilet is required, because otherwise you can have post-operative inclusion cysts. But if it is macerated, infected, grayish in color, then maybe you can remove it. And you made another important point about not digging up to the macula. So the hand over hand technique helps. You leave the suture long. As corneal surgeons, we are very used to trimming the suture very short. So if you don't see the posterior extent of a scleral wound, you leave a long tail-like, suture after tying the knot. You use that to pull the globe down, and then you can repair beyond. Finally, you can cut all the sutures flush as much as you can see, like you rightly said. Very posteriorly, the tenons will allow healing. So if you can't see very posteriorly, it is better not to dig around over there. And in scleral wounds, as important as it is to close the wound, and more important to cover it with conjunctiva, because sclera depends on conjunctiva for its healing and vascularity. You might have done a good job, but then it will necrose in the post-operative period. So while we speak about corneal and scleral wounds, it's very important not to treat conjunctival wounds very lightly. You may want to close, you may not want to close, but we need to put fluorescein, assess the conjunctival tear. If there is any tenons prolapse, then you have to deal with it. You have to abscise the tenons and close the wound. Otherwise, it will form a granuloma. So I can't see too many more other points to add in your versatile presentation. So in the interest of time, I think I will close my comments over here.
Can I ask two questions, Radhika
Absolutely,
and
sir.
Madhuvanti? I think the entire credit of Madhuvanti's presentation goes to you, Radhika.
Thank you so much, sir. Thank you. Not at all, actually. That's the first point that I made, that
Wonderful presentation.
you can only teach so much. It is
Yes.
up to the student to learn and take it forward. So, it was a 50-50 effort, and nothing gives me more pride, not even me speaking, it gives me more pride to see her speaking.
Absolutely. I liked your videos, Madhuvanti. It was so good. And the way you presented also. I have two questions. What is the suture? Because there's always a confusion. What is the suture used for scleral tears? Use Vicryl or nylon? Because I saw in one of the videos recently, they're using 10O nylon for suture, for sclera. The problem is 10O nylon is too fragile for sclera, in my opinion. So what is the suture, number one? Then Madhuvanti was mentioning that in 6 to 8 weeks, you'll remove the corneal sutures. Do you do that? Or
No,
you want
sir.
to wait for a longer time?
No, sir. I wanted to counter that point, but let me take your first question. Madhu, you want to answer the first question?
Yes, ma'am. Okay. We don't use 10-0 nylon. Ideally, we want to use 8-0 or 9-0 because they're thicker, little bit thicker than 10-0. And otherwise, we can also use 8-0 Vicryl. I've seen in a lot of places where we can use 8-0 Vicryl, especially if we are it's a very small tear. We can just use an 8-0 Vicryl so that it'll absorb after.
Correct. So I think that she made the point that it is more than the material, the gauge of the suture that is more important. Vicryl has the advantage of not needing suture removal, because quite often you will cover with conjunctiva and it becomes very difficult to remove a nylon suture. May end up causing infection or granuloma. So it is the thickness of the suture rather than the material that counts. Both nylon as well as Vicryl can be used for scleral wounds. Sir, about your second question, no, I wouldn't, because this trauma does not produce a clean cut incised controlled wound. There are a lot of factors which modify the wound healing, starting from the type of the tear, the steroid use, the age of the patient, the diabetic status, and whether it was a ragged wound, tissue loss was there. All this modify the wound healing. So I would follow up on the patient and look for two things. One is suture loosening. Second is the healing lines of fibrosis, as I call it. Those white lines which straddle the wound. So once you see them, then you know that collagen repair has happened over there and it is safe to remove the suture. So an unguided timeline of 4 weeks, 8 weeks cannot be kept for wound-related suture removals. And here also, in the scar that is produced by trauma, even when the sutures are in place, after removing some of them, if some of them are still present, the pros contact lens or the scleral lens comes as a boon to us at this time. So earlier we couldn't give them contact lenses because you need to remove the sutures first. But even a few sutures are there. Nowadays we can give pros lens because it's got a good clearance. It sits on the sclera, and therefore we can visually rehabilitate the patient even before complete suture removal. So to answer your question, those white lines should be seen. Only then we can remove the suture.
Thanks a lot. Thank you. Thank you so much. Very clear.
Thank you, sir.
So we'll go on to the next Mohan. Are you introducing the next speaker?
Yeah, next speaker is I'm very proud to introduce my very good student, one of the best outgoing students of DNB from Rajan Eye Care. Dr. none other than Dr. Mukundan Rajarajan. And Dr. Mukundan is a top guy. He's in charge of the cornea and ocular surface in Shankar Nethralaya. And he did his MBBS from Pondicherry University and then DNB residency, of course, from Rajan Eye Care. And he did a fantastic cornea fellowship from L.E. Prasad Eye Institute. A lot of publications, a lot of research work. Mukundan is a really, what do you call, a very dynamic consultant, I would say. And over to Mukundan. He's going to talk to us on a very important topic, pearls in the management of acute chemical injuries, which is, I think, is a very, very, what do you call, the current topic, I would say. Over to
Thank you so much, sir. Thank you for so much for the kind introduction, sir. And thank you, Sujata ma'am, for giving me this opportunity. So I'll move on to my topic, pearls in the management of acute chemical injuries. As we all know, chemical injury is an acute ocular emergency, and prompt action can minimize damage. Severity depends upon the type of chemical injuries. As we all know, alkali tends to penetrate more and can cause more morbidity when compared to acid injuries, as well as the duration of exposure. So when a patient of chemical injury presents to us in emergency, a brief history is needed to know the mode of injury, followed by quick systemic examination as well as an ocular examination. In case of a children, if child is not cooperative, examination under anesthesia is mandatory. This is followed by a complete removal of the offending agent through thorough wash. And in case of embedded foreign body, we manually remove through forceps. So ideal wash of minimum 30 minutes of duration with 1 to 3 liters of irrigating fluid, and check pH every 15 to 20 minutes and check pH 15 minutes post wash. So this slide shows various irrigating fluids available. Which is best? So it depends upon the pH and the buffering capacity. So amphoteric solutions like diphoterin and cedarode are most effective when compared to other irrigating fluids. But the important point is prompt irrigation is more important than the choice of irrigation. And in case of calcium particles embedded in the cornea, in case of chemical injuries, we can do chelation with EDTA, either in OPD basis or in the theater. So after thorough wash, we document the visual acuity and we do a detailed slit lamp examination. We look for 3 I's and 2 E's. They are ischemia, inflammation, and intraocular pressure, and 2 E's are epithelial defect and exposure. So these I's and E's are very important to decide the further course of the management and to decide the prognosis. and if a patient is cooperative, a posterior segment examination documentation is also necessary. So first eye is scleral ischemia. Here we can see a blanched white area without any blood vessels. So it can be either localized or it can be a generalized scleral ischemia. Then look for signs of exaggerated inflammation like presence of granuloma. And intraocular pressure, it can be either raised due to a compromised uveoscleral outflow, or it can be low in case of exaggerated inflammation and ciliary body shutdown. We'll move on to the 2 E's. Look for the epithelial defect, look for the corneal, conjunctival, as well as the tarsal epithelial defect, as well as look for exposure changes. So after thorough examination, we grade the chemical injury. Earlier, we followed a Ruperol classification, which grades based on the corneal damage as well as the involvement of the limbal ischemia. So, according to Ruperol classification, greater than 6 clock hours of limbal involvement is grade 4 and it has a very poor prognosis. But now with better understanding of the limbal epithelial cells, we know that even with 2 clock hours of LT limbus is sufficient for epithelialization. So DUAS has subdivided the grade 4 into further grade 5 and grade 6. And DUAS also considered the conjunctival involvement, and he preferred the term limbal involvement than limbal ischemia, as limbal defects can be present without limbal ischemia. But still, these classifications have the following limitations. The laterality and the nature of injury was not mentioned, and the scleral ischemia was not considered. The intraocular pressure and exposure are not considered. So for example, this is here 3 images we see. All 3 are grade 6 according to Dua's classification. But the prognosis vary in all these 3 cases, and thus will AMT, simple AMT alone will be sufficient? The answer is no. So to overcome these flaws, Dr. Iyer et al. Have come up with ethics grade classification, where E for epithelium, P for pressure, I for ischemia, and X for exposure changes. In epithelium, it's further subdivided into limbal epithelium, conjunctival epithelium, corneal epithelium, and tarsal epithelium. And pressure, we look for the raised pressure or low intraocular pressure, and ischemia and exposure are graded. So EPICS grading is done every 1 to 2 days. The goal of our treatment is to achieve an endpoint P0, I0, and X0. For example, this is the grade 6 case of chemical injury, where severe chemical injury. The EPICS score will be as follows. Left eye, alkali injury with EPICS grade L6, C4, K2, T4, and pressure plus raised IOP, and no ischemia, no exposure. So this EPICS grading is available online in this website. So as I already mentioned, management depends upon these I's and E's. The goal is to reduce the inflammation, manage ischemia, and control pressure, as well as facilitate epithelialization and manage exposure. So to control inflammation, we have a topical corticosteroids, which is started immediately after the chemical injury. Ideally, topical prednisolone 1% solution or any equivalent potent steroids, which is given on a frequency 8 to 10 times a day. And the other medications to support repair or use of oral tetracyclines, they are a free radical scavenger with antioxidative mechanism, and they also have a collagenase inhibiting properties. The dosage is around doxycycline 100 mg BD for 2 weeks. It's avoided in kids and pregnancy. We also have a topical sodium citrate, which is a calcium chelator, and also which inhibits collagenase. The dosage is topical sodium citrate 10% every 2 hours can be given. And ascorbic acid, they act by restoring the aqueous level of ascorbic acid, and they reduce the risk of perforation when used in combination. So topical drops are used every 2 hours, or oral ascorbic acid 1 to 2 grams 2 times a day. Then factors helps to facilitate epithelialization. Always debride the necrotic material, and bandage contact lens can be used to avoid the windshield wiper effect, and use of copious lubricants. Autologous serum and platelet-rich plasma can be considered in non-healing epithelial defect before planning for amniotic membrane transplant. Usually, grade 1 to 3 chemical injuries without coexisting ischemia can be managed medically. Then for control of intraocular pressure, we give oral acetazolamide, and topical PG analogs are alpha-2 agonists may not work as the uveoscleral outflow is compromised. And in case of low intraocular pressure, we give systemic oral steroids along with topical steroids. A brief note on surgical management in acute chemical injury. We can consider the amniotic membrane as it is having anti-inflammatory and anti-scarring effect. It helps in promote epithelialization. Procara is an FDA-approved cryopreserved amniotic membrane ring, which can also be placed to facilitate epithelialization. And a brief note on allosolate in case of chemical injuries. So in case of severe chemical injuries, there are almost total loss of epithelium. Providing an external source of epithelium from an allogenic limbus tissue or autologous mucosal tissue can help in faster epithelialization, thereby reducing inflammation. So this is the case of grade 4 chemical injury managed with amniotic membrane transplant. We can see in 2 weeks follow-up, there is a surface has completely epithelialized. And to manage exposure, we can consider torsography or skin graft and tenonplasty for splenal ischemia. Other supportive treatment like cycloplegics and prophylactic antibiotics also considered. Just I'll end my presentation with this case example. It's a case of a 36-year male with an alkali injury. So here you can see there is almost total loss of epithelium. There is loss of corneal as well as conjunctival as well as tarsal epithelium. So it's EPICS classification, left eye, alkali, EPICS grade L6, C4, K2, T4 with raised intraocular pressure. This patient, since there is total loss of epithelium, An allo slit was considered to give an external source of epithelium for faster epithelialization. So this is post-op picture post allo slit. This is 1 month picture where the patient had a corneal defect, the conjunctival tarsal defect has healed. And when we repeated allo slit, the surface epithelialized, and this is the picture 6 months follow-up. The intraocular pressure is also managed by use of topical anti-glaucoma medication. There was no ischemia, no exposure changes. This is a patient 6 months follow-up, is completely epithelialized with partial LSCD and with BOSP is having 6-12 vision. Just to summarize, acute management is crucial. Grade 1 to 3 chemical injuries can be managed medically. And as I already told, the 3 I's and 2 E's are very important. And prompt management can give better outcome. Thank you. Thank you.
Thank you, Mukundan, for the wonderful presentation. I just wanted to ask you one question because Bhaskar is going to discuss, I'm sure. After that,
Sure. That was a very wonderful presentation, Dr. Mukundan. Just to kind of sum up, the management in an acute chemical injury goes a long way in what the rehabilitation we can do in the chronic phase. If you manage the acute phase well, you might be able to salvage an eye. You might be able to avoid having to do a corneal transplant subsequently. You might be able to avoid going down the route of keratoprosthesis to salvage the vision of those patients. Again, if you're looking at a bilateral injury versus a unilateral injury, the desperation in trying to salvage a bilateral injury goes a long way forward because you need to give some vision to the patients. Most of the times, as ophthalmologists, we don't have the habit of going into the surgical room second time, third time, fourth time. So when you deal with a very bad chemical injury, if we have to repeat the amniotics, if we have to take the patient up, we feel guilty feeling that there is something wrong. The plastic surgeons take the patient up 25 to 30 times into the OR to get the scar revised. So it depends on the severity of the disease. It is not an indication of your competence or your surgical skill or the outcome that you can. But you have to give it your best so that you can have the best outcome as far as the patient is concerned. Most important aspect in terms of chemical injury and the questions that people ask is, one, with an epithelial defect, would you give steroids? Yes, for a chemical injury, the treatment is steroids. You will start steroids. It will be 1 hourly on the first day of presentation. If the patient presents 10 days later or the patient presents 2 weeks later, then you have the concept of steroid causing collagenolysis, and people are asking us whether you would want to continue. Yes, you would continue steroids, but if the defect has not healed for 10 days, that tells you an indication you need to intervene. It probably was a much more severe defect that has not yet healed. You will need to go in, you will need to consider doing an amniotic membrane, and you will continue with steroids. If it's a grade 4, grade 5, grade 6 duas where the conjunctiva is also not available for the surface to epithelize, you will need to consider putting in an allogenic stem cells to epithelize. The idea is to get the epithelium on. The moment the epithelium is on the surface, the ocular inflammation comes down. If you're able to get the epithelium on the cornea before it scars, before it melts, before it perforates, you would have probably saved the eye from requiring a corneal transplant. And that's what we actually showed in our paper when we compared eyes which underwent alloslit versus eyes which underwent only an amniotic. The number of procedures that we had to do in the chronic phase significantly reduced. The number of transplants that we had to do in the chronic phase significantly reduced. The severity of symblepharon in the chronic phase significantly reduced. So managing acute injury aggressively is very, very important to maintain a good outcome. The next thing is in terms of vision. So Mukundan showed a case where the cornea was already opaque, so vision is low. But quite a few times they will actually come with a very good vision because your cornea will still be clear. And as you treat, their vision will drop. That's also something that you will have to keep counseling the patient, that there is no skin, so your vision is good. As the skin grows, whether as it conjunctivalizes, the vision will drop. So even if you look at your retrospective literature and try to see, you will say presenting vision was 6/9 and now the vision is counting fingers. But that's expected because there was no epithelium. Your aim is to get epithelium on. Once the epithelium is on the surface, the eye quietens. If you have a very severe intraocular pressure, that needs to be managed. But more importantly, if you have a very hypotonic eye, that becomes more from a prognostic point of view, it indicates a more severe damage because there is a complete ciliary shutdown. So there, if it's a bilateral and if the pressure is not at all building, you might have to think outside the box, that like we did in one patient from Kashmir who had been referred with bilateral chemical injury with significant hypotony, and the eye was becoming prethesical. So one eye we decided to operate and put in silicone oil just to retain the globe contour, and then we did a keratoprosthesis, and she's still retaining around 624 vision in her only eye in at about a 4-year follow-up. So certain times you will have to think outside the box. Make sure that your consent is in place. Make sure that you document the I's and E's as mentioned. And at each visit, look at the epithelial defect, look at the scleral ischemia, look at the pressure, look at the exposure. If you are looking at these factors at every visit and documenting, whenever there is a worsening, you need to intervene. If in a week's time there is no improvement, you need to intervene. So no improvement is also an indication to intervene. Worsening is also an indication to intervene.
Thank you.
Sir, how early will you do an allo-slit? How early, as soon as you see the patient? How early will
So
you do an
if it's a grade 4, grade 5, grade 6, I know there is no conjunctival epithelium left, I would do it as and when I would normally start the patient, put the patient on a contact lens, start topical steroids, send him for physician clearance for the surgery, do an amniotic and put an allo-slit. So it might be even day 4, day 5, day 6, because I know it's so large. It's even if it heals with conjunctiva, by the time it heals, it's going to be 2 months. He'll end up with a corneal scar. My role is to avoid it reaching a stage of corneal scar. If I can do that, his auto-slit or allo-slit in the subsequent phase becomes a lot more easier. In the case that he showed, because of allo-slit, he was able to get away with just a pros lens now. Otherwise, by the time it would have healed, he would have required an LK. Once you go down the LK, PK line, the outcomes keep getting worse.
That's great. Thank you. Thank you.
I had to compliment.
Also, I think, if I'm not mistaken, these allo-slits don't require immunosuppression because they are given for short-term benefit.
Yes. So the idea here is just to, you just want to win the war. You can fight the battle for vision subsequently, but sometimes even this will work because because the inflammation is reduced, some of the inherent limbal cells are also able to survive because the inflammation comes down. The problem is in chemical injury, there is no way of quantifying the extent of limbal deficiency at the acute phase. When we say limbal deficiency, it's only the conjunctivalization, which actually is a healing response which comes subsequently. That's why Dua uses the word limbal involvement rather than the word limbal ischemia, because you can't quantify. You can only look at a scleral ischemia. Again, a scleral ischemia, also you might mistake initially because the conjunctiva is chemotic and it might look as if there is no vasculature. Once you cut the conjunctiva and if it is not bleeding, it indicates that there is no vascular supply and you will need to mobilize vascular pedicle to cover that area. So a lot of times, just by the allo-slit, if these existing cells are able to survive because the inflammation comes down, you will have a cohort of allogenic cells and an autologous cells, which itself will survive. And as these allogenic cells fail, it gives time for the autologous cells to kind of migrate, and you will have, say, a partial deficiency or something like what he showed is mostly like a partial deficiency, which is there, which is why it is working, because it's not that the allogenic cells are still working over a 6-month period. They would have got replaced by, because if the patient is not on systemic immunosuppression, they would have been replaced by the autogenic cells.
Can I make just a comment? Since Radhika is also here and Bhaskar, Mukundan, really very nice presentation. I just want to know, is there any flow chart for acute chemical injuries? For example, we have flow charts for acute endophthalmitis. What are the do's and don'ts? What are the intravitreals to be given? Everything. We have got flow charts. What are the protocols to be followed? In
You
acute
showed on the
chemical
epics grading, which had
Epics.
No.
grading.
Yeah.
We have a flowchart
For a common
our
ophthalmologist, because when they treat chemical injuries in the acute phase, what are the do's and don'ts? Is it possible that you can develop something and which can give it to everybody so that it will be easier for them?
Sure. So I think we have actually put the algorithm in our EPICS classification in ocular surface. We can probably share it here in the group somewhere and it can be circulated. From the common ophthalmologist point of view, the most important thing is, one, stain the surface to look at the extent of the defect. Two, start steroids. Again, when you're staining the surface, because there's so much of watering, you might actually have to stay in it a couple of times because the fluorescein gets diluted by the tears. So you might not be able to see the extent of defect at the first instance. So you might have to put the fluorescein a couple more times, and then you'll be able to see the extent of the defect. If there is significant conjunctival involvement almost till the fornix, and the eyes and the cornea is completely deepithelialized, you will put a contact lens, you will start topical steroids. But if you don't have too much of experience dealing with this, you might want to refer the patient earlier to somebody who specializes in
Immediately.
it. If you want to hold on, maybe the target would be about 3 to 4 days. If by 3 to 4 days you do, if it's a very superficial injury, but it has caused a shed off of the conjunctiva and the corneal epithelium, it will start responding in 3 days time. If you see a healing response in 3 days time, great. But if not, it makes sense to kind of send it across at that point of time.
Okay.
If it's a pediatric patient, either you do an examination under anesthesia to look for retained Lyme in the fornix, or you refer it to a higher center where they can do the examination under anesthesia. Because even if you pull the lids in a crying child, you will not be able to assess the extent of damage in the OPD per se.
Okay.
Thank you, Dr. Bhaskar. I think we'll move on to the next excellent talk by
Yeah.
Mukunda. Fantastic discussions.
Thank you very much. And we go on to the next speaker who's going to talk to us on glaucoma, Dr. Archana Nivash. And I'm very, very honored to introduce her because she is also a DNB student from Rajan Eye Care, and she's head of glaucoma now for Rajan Eye Care for the past almost 10 years. And she graduated from Government Kilpauk Medical College. She is the recipient of the Venkateswamy Gold Medal. She is an outstanding student and very good glaucomatologist, very good clinician, very good surgeon. And she is actually an all-rounder. And over to Dr. Archana Nivash to management of angle recessive glaucoma. Archana, all yours.
Thank you, sir, for the kind words. And thank you, ma'am, for giving me this opportunity. So the topic for today is management of angle recession glaucoma. So angle recession is, as we all know, it is the pathological split between the circular and the longitudinal muscle fibers of the ciliary body. And it is the most common cause of late onset post-traumatic glaucoma. So in the setting of a trauma, the most common reasons that we come across is a shuttlecock injury and other sports-related injuries. But angle recession can also occur with motor vehicle accidents, especially because of airbag deployment. It can also be seen in the setting of industrial injuries and also after certain surgeries like a PK. So my management approach for angle recession is first and foremost detecting it. So careful clinical examination and gonioscopy is irreplaceable as far as detecting angle recession. So the presentation of angle recession glaucoma, the ocular hypertension that occurs, it has a bimodal pattern. So the first peak occurs early within a year of injury, and it is not related exactly to the extent of the recession. And the hypertension arises because of the fact that the ciliary body regains its secretory function after the initial shutdown during the trauma. The second peak is what occurs insidiously several years after the trauma, and this is related to the extent of recession. So greater the recession, greater is the risk of developing glaucoma. So why does it happen? The mechanism goes like this. So the anterior posterior compression of the globe occurs into the orbit, and this forcefully displaces the aqueous humor towards the angle. And the acute stretching, if it exceeds the elasticity of the tissue, it damages the angle structures. So the IOP rise happens not because of the angle recession per se. It happens because of the fibrosis that ensues in the trabecular meshwork and which obliterates the Schlemm's canal. And it has also been described that a hyaline membrane sometimes forms over the angle. Hyphema has been found to be the most common association with angle recession. However, it can occur as an isolated factor as well. So many patients are unaware of this injury, and this is the reason why there is a delay in referral to the ophthalmologist. So whenever there is an angle recession, it has been postulated that we also have to look for certain other injuries in the eye, namely cyclodialysis, zonular weakness, and retinal dialysis. We have to look out for all these conditions as well. So sometimes there is a correlation between the site of the injury and the probable site of angle decision. And it has been observed that there is extensive angle decision occurring when the impact of the injury is central corneal. So how does it look in a gonioscopy? So there is posterior displacement of the root of the iris, and the exposed ciliary band appears widened in an irregular manner. And it is very important that we do the gonioscopy in the contralateral normal eye to document the asymmetry. And there's also localized deepening of the anterior chamber. In long-standing cases, diagnosing recession can be tricky because there can be formation of goniosynechiae, which may mask the angle recession. ASOCT can also demonstrate recession, and so can UBM. However, gonioscopy remains the gold standard investigation because it is inexpensive, and it also allows us to dynamically assess the angle, like for example, pigmentation, and the structures can be intended. However, it relies purely on the observer's experience. ASOCT is a more objective way of doing things, but it does not give us the dynamic idea. So how do we manage the recession? So first, managing the IOP. So as in any other glaucoma case, we set our target based on various factors like the presenting intraocular pressure, the age of the patient, and the extent of disc damage. And medical management, a specific word about prostaglandins. So we avoid them in the acute phase. However, later on, they have a role because they enhance the uveoscleral outflow, because we know that in these recession cases, the trabecular outflow is impaired. Pilocarpine drops are avoided because they not only reduce the uveoscleral outflow, they are also pro-inflammatory. So there are various options available. So selective laser trabeculoplasty can be tried over the normal angle, the residual normal angle. It has been found to be safe and effective with about a 20% reduction in intraocular pressure. But the results can be unpredictable and can wane over time. So as far as the surgery of choice is concerned, it is trabeculectomy with mitomycin C. And the success rate is comparatively less. When you compare it with a clear case of POAG, the success rate is less. And that is understandable because there's a higher incidence of bleb failure in these cases. And it has been observed that anti-metabolite usage increases the success rate, and trabeculectomies usually perform better than shunt surgeries in this setting. So I want to present a case of angle recession which we handled. It was a 40-year-old male patient who had undergone LASIK before, and he had a shuttlecock injury, and he had been treated elsewhere for about a month, and he was still on 4 anti-glaucoma medications with his intraocular pressures around 23 millimeters mercury. And this is the slit lamp photograph of the anterior segment, which shows a barely seen LASIK flap, a mid-dilated pupil, a traumatic cataract with the infranasal subluxation of the lens, maybe a dialysis of about 2 to 3 clock hours, and some folds in the posterior capsule. And gonioscopy showed an extensive 360-degree angle recession in the involved eye, and the other eye was a normal open angle. So posterior segment examination shows a hazy media and not much of disc damage because the presentation was just about 2 months after the angle recession. So during the follow-up, we tried to medically manage him. However, he had recurrent bouts of iritis. Whenever the prednisolone eye drops were tapered, he again had iritis, and he did not tolerate prostaglandin analogs. And we went ahead and did a phacotrabeculectomy with MMC and pupilloplasty, and CTR was used. So this is my short surgical video. So a fornix-based conjunctival peritomy has been done, and a triangular flap is being raised. MMC is used in sponges. We use them in sponges, 0.4 milligram for 2 minutes, and washing it thoroughly. And we can see that the rhexis and the nucleotomy has been completed with femto laser. In the bag, phaco, direct chop to avoid zonular stress. And we can see the laxity in the bag and viscoelastic generously being used. And there we can see the area of zonular dialysis pre-existing. Carefully, the cortex and the epinuclear sheet being removed, and a CTR being placed in the involved segment. Nudged into the bag, and a 3-piece hydrophobic IOL being placed inside the bag. And a single pass orthopupilloplasty also being performed for reducing the size of the pupil more so than for reducing the IOP. And we can see the trabeculectomy being completed with a punch and fixed sutures being used. and a watertight conjunctival closure and bleb at the end of surgery. So post-operatively, the course was not a straightforward one. The patient did have fluctuations in his eye pressure, and he did have a vascularization of the bleb, and we could not do the laser sutural lysis because he had a thick TNOA capsule. Despite multiple 5-FU injections subconjunctivally, his IOP remained high, and therefore we decided to go and do a bleb needling, following which the intraocular pressure came under control. There were no CDs, but after about 6 weeks, he developed a cystoid macular edema, which, however, responded to topical NSAIDs. So we followed up this patient for about 1.5 years, and he is doing well. His intraocular pressure is still under control, and he has stable and normal visual fields, and his CME is resolved. So just wanted to highlight that in a trauma case with angle decision, when we're planning for surgery, it has to be, the examination has to be meticulous, and we have to be ready to face the complications on table. And equally important is the post-op follow-ups. They have to be meticulous so that we can detect the complications early and manage them accordingly for a good long-term outcome. So apart from this, implant surgeries are also indicated, especially if we are dealing with extensively scarred surfaces in the setting of multiple trauma in the eye. And there is also a report of primary implant surgeries being done in Indian eyes with good surgical success and minimal complications. MIGS also has a role, and it can be considered as an adjunct to medical management if majority of the angle is open, and especially if we have to do a cataract surgery in these patients. And it is also a consideration in patients in whom we want to avoid trabeculectomy. So the mixed procedures which have been described in literature as GAT, trabectome, and penetrating canaloplasty. So my take-home message is angle recession is often, glaucoma is often undiagnosed because it presents late and it can be silent. Gonioscopy is the cornerstone of diagnosis. Managing it can be straightforward or complex depending on the coexisting ocular pathologies. Patient education about lifelong follow-up of post-angle recession is extremely important so that we can limit the visual disability because of this type of glaucoma. Thank you.
Dr. Devendra, your discussion, please.
Okay, so good evening, madam, and good evening, sir, for giving this opportunity. I think I rewind my PG days by listening the cornea lectures actually. So very wonderful. So coming to the angle recession of glaucoma, a very nice presentation. I think the best way to deal, the way you deal the case is the best way. You thoroughly cover all the points about the angle recession glaucoma, but keep in mind when the following the trauma, only the 50 to 80% patient will have the angle recession, and out of them only 6 to 20% patient will develop the angle recession glaucoma. So apart from when the glaucoma is developing, always keep an eye why your IOP is going to be high. Apart from the angle recession, keep check your steroids also. Sometimes steroid response is much more higher in the angle recession cases in compared to the normal population. So always look for it. Then when you grade your angle recession, so the angle recession, what's causing, how much damage to the optic nerve, it is very necessary to assess. So your management should be based on the how much optic nerve head damage is there. If it's a mild, moderate, you can manage with the medical management. As you said, all the we have to treat like a POAG, except a few points like you mentioned, acute phase we should avoid the PG analog because they're the pro-inflammatory. Then use the aquasuppressant, they're the best way. And then later on phase we can use the PG analog if glaucoma become refractory. And you talk about the pilocarpine. So pilocarpine we have to avoid throughout the initial to beginning because it can increase your angle recession because it's working on the ciliary muscles. So apart from this, when you managing it, so coming to SLT, really the results, few studies are there, but my practical experience, SLT doesn't work in the angle recession glaucoma. When coming to the trabeculectomy, really is a gold standard, still gold standard because widespread everybody can do it. So coming to, I will always prefer use the injection, especially in such refractory cases because they are the highly refractive. So use injection MMC. Apart from these cases, use always releasable suture. So you can early post-op period, you can intervene. Apart from that, when you before trying to the mix, if I was in your place, I prefer to do the mix surgery. I'm a profile mix surgeon. I do a lot of mix. So my first choice of surgery, medical management. If fails, goes to the mix because become a minimal traumatic, and usually such cases have the iodinalysis, no, sorry, have the had the jonular weakness, high risk of the PCR. In such cases, instead of tracheotomy, they are always high risk for the complications. So better do the mix. Mix, you can do the KDB, you can do the tracheotomy, or you can do the GET. So these are the first preference for the surgeries. If these fails, then you do the traps. Apart from the traps, and sometimes they come present with the complex scenario, so you can use the tube. Either the I prefer to the valve implant, either the RD, or RD you can put an anterior chamber in sulcus, even if for the posterior chamber also, if there is some posterior intervention is required. Apart from that, rest all things you covered, and this case was very nicely managed. I think madam done the wonderful job by doing the femto, but I will suggest the par excellence level, but I will suggest for my colleagues, be careful, be ready, do the normal FECO. That's
Correct.
we can do the femto. I know it's indicated. It's well, femto is well indicated and experience, and you can do the mature
Especially when you have
hypermature
zonal
submaximal.
dialysis, femto is easier to do the rexis when you
I
have.
know, sir. I know. But it works in, sir, your hands and
You're
madam's
just
hand, but not
bypassing one
all.
step.
Yeah.
Thank you.
So it's nicely.
Shall we move on to
nicely
the next? Thank
Yeah. Thank you, Devendra and Archana, for the wonderful talk and discussion as well. And next, I have the pleasure of introducing Dr. Jebin Bryan, whom I call the FECO Dynamo. And no, if you call Kapil Dev the Haryana Hurricane, Jebin Bryan is the Coimbatore Hurricane here. He's one of the fastest surgeons in FECO. And I'm really amazed by his speed, his competence, and he's got more than 40,000 cataract surgeries. He's an expert in pediatric ophthalmology. He's an expert in secondary IOL fixation, very innovative guy, very dynamic, and he's head of the cataract and IOL and the pediatric ophthalmology at Aravind Eye Hospital, Coimbatore. And over to Jebint on a very important topic, management of traumatic subluxated cataracts. Jebint, all yours. You're muted. You're muted.
Yes, sir. Now, am I audible?
Yes, sir. Go
Is
ahead.
screen visible, sir?
Yes.
Yes.
First of all, I thank Sujata ma'am for giving me this opportunity. And
Slides are not advancing?
yes, now it's fine, sir.
Yeah.
So today I'll be talking on traumatic cataract, mainly the traumatic subluxated cataract. And I tell it's a kind of a box of surprises. And it's not the routine cataract because traumatic cataract is kind of it contains a different area of anterior segment reconstruction, including iris repair, zonular weakness management, and secondary IOL fixation techniques. And while managing these kind of cataracts, the surgeon should have an adaptive mind, flexible to change the plan in between cases, and to have and should be comfortable in managing complex cases, including skills placing the CTR, CTS, and confidence in managing anterior both limbal and pars plana, and iris reconstruction procedures also. The tools, so before taking up these cases for surgery, or we should have these available tools like different kinds of OVD, dispersive, cohesive, the hooks and implants, the suture materials like TNOA nylon and nano prolin sutures, the micro instruments with micro forceps and scissors, and IOL options. Both the IOL and three-piece IOL have to be kept, and iris claw IOLs also have to be ready. I'll be sharing few cases. I'll be showing the main steps. And this first is a case of 6 o'clock of iododialysis, where I managed to stabilize the bag and place the IOL. So first is this is a crucial step that is making the rexus, because if we get a rexus extension, it won't be possible to stabilize the back. Then we have to go for a second trial procedure. So I was able to complete the rexus of 4.5 to 5 mm. Then I placed a CTR. CTR gives a circumferential support. However, because of this extensive zonal dialysis, CTS is also needed, the capsular tension segment, to give a focal support. So the one arm of the double arm straight 9 Prolin suture is looped into the fixation holes in the CTS. Then the CTS is taken into the antechamber and placed inside the capsular bag where there is more amount of zonular weakness. Then a scleral groove is made 1.5 mm away from the limbus, and the 26 gauge needle is passed through the sclera and taken into the antechamber. And the first arm of the double arm straight Prolin suture is taken, is rail-loaded and externalized. And the similar fashion, the second arm of the Prolin suture is also externalized. So after that, the CTS is placed in the back where there is more amount of zonular weakness. The knot is not fixed, a temporary knot is placed. Now the bag is stable, so we are able to proceed with the smooth phacoemulsification. I prefer to do a direct chop in these cases, and I divide into multiple fragments, at least minimum 6 fragments, and then emulsify one by one, gently. Till now, I haven't noticed any vitreous prolapse. When I'm doing a cortex wash, I could able to see some prolapsed vitreous strand. So I have to do a anterivitrectomy, minimal anterivitrectomy after staining the vitreous. Then I am able to complete the residual cortex wash gently. Then I placed a single piece IOL in the bag. So I prefer to make the final fixation knots after doing the visco wash and forming the anterior chamber, because then only I will be able to get a proper centration. So now the well-centered IOL, the CTS provides global support, but the CTS provides a targeted support. So now this is a case of cataract taken for phaco. When I'm entered the anterior chamber, I could able to see a gross subluxation. Then I have to change the plan of making a scleral corneal tunnel and then remove the lens along with the bag gently. And after doing anterivitrectomy, I place the retropupillary fixation of iris claw IOL. So in this case, a PI is must to avoid glaucoma, pupillary block glaucoma. The wound is closed. And next is a case of 6 clocker of zonal dialysis with diurodialysis. So a 180 degree apart, I mark and make these scleral pockets before entering the anterior chamber. So again, a scleral groove is made. Anterior chamber is formed with high molecular weight OVD, and the dialyzed iris is unfolded, and one arm of the double arm straight 9 Prolin suture is passed through the sclera, and the peripheral dialyzed margin of the iris is taken and it externalized through the paracentesis made, and the first arm is going railroaded into the 26 gauge needle, and care should be taken accidental incarceration of the corneal tissue in these needles should be avoided, because if it is taken, we have to do the procedure from the beginning again. 2 suture bites, that means like totally 4 needles are passed and it's tightened, and now the scleral corneal wound is made, and the lens along with the bag is taken out. And after doing vitrectomy, thorough vitrectomy, now 23 the microforceps is passed through the sclerotomy made in the scleral pocket, and the first arm of the loop of the IOL, haptic of the IOL is externalized, and now the second haptic is externalized with the help of handshake technique. And now both the arms haptics are externalized. This is the modified Gabos technique, and both the externalized haptics are tucked in the scleral pockets made, and the scleral pockets are sutured, which is not mandatory, but I prefer to suture with the atovicral suture. So, and the conjunctival wounds are opposed, and the scleral wounds are closed with 9O nylon. You can see a well-centered IOL with the near round pupil. And this is the last case. This you can see inferiorly, they can like 2 to 3 clockers of zonal dialysis. So first I manage, as because it is less than 3 clock hours, I could able to stabilize the bag with the help of CTR. Then I could able gentle hydro. I could achieve a proper rotation of the nucleus. Then I proceeded with phacoemulsification. Then after cortex wash, I placed a 3-piece IOL in the bag. Then the bigger task of tackling the mydriatic pupil, I used a microforceps to see the distentability of the iris and the left, if there any other tear happened in the pupillary margin. Then it's done in 3 segments. The first arm of the double arm straight Prolin suture is introduced, and bites are taken as close as possible in the pupillary margin. So the first segment is done. Now the needle is externalized and reintroduced in another paracentesis for the ease of mobility. And the second segment, similarly, close bites are taken. And it's externalized. Now the first arm, I have done the first segment and second segment. Now the second arm, I'm taking bites in the third segment. So the sutures are taken closely. So the progressively tightening it to get a round pupil. The the needles are taken through the main wound, and knots are taken and titrated according to the desired size of the pupil. As you see, the pupil reforms beautifully with the central round aperture. With this cosmetic and functional reconstruction. Thank you.
Superb presentation. I think we'll have Dr. Sirish discuss it.
Thank you, Dr. Sujata, for giving me this opportunity. I thank Dr. Mohan Rajan, Dr. DC also. So very nicely done surgeries, Dr. Jabint. You have shown almost all the varieties of subluxated cataracts, and the first one is actually it was looking like a congenital variety of subluxation, and you have used CTR and CTS. Maybe like that is around 5 to 6 clock hours. Like we could have the other way of doing it is maybe like we could have done a Rexis and supported the capsule with the capsule hook, and then finally once the cataract was removed, we could have placed CTS alone. Like of course, you have done a wonderful surgery, and the final result looks excellent. And the second case is a straightforward case of subluxated cataract, wherein you have done an intracapsular cataract surgery, and the iris clip IOL was placed. And my preferred second IOL is iris clip IOL. It is very quick, and for anterior segment surgeons, I think that is the best way to go. Like it works very well, and there are comparative studies wherein they have compared iris clip IOL results with the SFIOL types of modifications of SFIOL is there, but final, like as far as the CME or other complications are concerned, at least clip IOL and SFIOL, there's hardly any difference as far as the outcome is concerned. This is very quick. It takes 4 to 5 minutes for us to complete the procedure. And the next case is the iridodialysis with ZD, and wherein you have put a iris clip IOL, and
SFIOL.
sorry, iris instead of iris clip, you have put a SFIOL. The third case. Why? Any specific reason you have chosen a SFIOL in this particular case? Because the pupil became all right and it became centered also, and I could have even gone ahead with the iris clip IOL in this case. Any
Uh,
specific reason, or you
Sure.
just want?
Actually, even its pupil is becoming round, it is not completely, we couldn't become very small because of the traumatic, you don't constrict also because of the area, in the area of zonal dialysis. So that, sorry, iridodialysis, so that if I place an iris claw IOL, it will tilt to the, towards the anterior side. That's the reason I prefer to do
Yeah.
SFIOL in such cases.
Nice, very well done surgery, and finally the result was excellent. And a few tips for maybe the beginners, like whenever you encounter a case of traumatic cataract, along with some corneal tears, like if it is an acute case of corneal tear with the um, cataract, so you have to decide whether to go ahead with the cataract corneal suturing alone, or along with that you should even aspirate the cataractous lens. If there is anterior capsular tear, and if there is already the hydrated cortex, which is there in the anterior chamber, maybe in such cases alone you should go ahead and combine this like corneal tear suturing with the cataract extraction. Most of the patients who are young are prone for this trauma. They have soft cataracts, very easy to aspirate these cataracts. But if at all the anterior capsule is intact and if there is no material in the anterior chamber, there is cataract, but we can wait for the corneal wound to heal. Maybe after 6 weeks, when once you remove the suture, wait for another month or so, and then you can do a more definitive cataract surgery in those cases. And he has shown a variety of procedures with the dialysis. A very small dialysis area of dialysis, 3 clock hours, 3 to 4 clock hours. CTR itself is sufficient, and it can be inserted at any stage of the surgery. And CTS is indicated in more severe cases of zonular instability, and typically like if the ZD is more than 4 clock hours, or if there is a ZD with severe phacodonosis, and one or two CTS can be placed. And unlike CTR or MCTR, the CTS, it can be placed in the presence of anterior capsular tear also, and even in the presence of a small piece rent, you can even place a CTS because it's locally placed, so you can easily slip this into the area where it is needed. And regarding the pupilloplasty, it's very nicely done, but it's very difficult. It takes so much time for the encerclage. I have done two cases, and the results are good, but eats out your surgical time. The technique which he has shown is the lasso technique, so works well. And even the single pass fourth row, which was shown in the earlier presentation by Dr. Archana, also works well in these cases with the traumatic mydriasis. Even the old technique of mechanical suture, where you can introduce your sutures through the two corneal paracentesis and approximate these iris edges and bring it out through the third incision and tie it. So that also works in these cases. So very well presented, Jagvint.
Thank you. Thank you.
This is what was my comments.
Very nice. Shall we go to the next one?
Just have one comment. I think some of these cases, if you have done a femto cataract, it would have saved a lot of trouble, because like we showed in Dr. Archana's case, it's much
But,
easier to do a rexis.
Definitely.
Yeah, he didn't struggle in doing any rexis.
Yeah, he
Of
didn't
course,
struggle, but
the first case also the rexis
Jabin, he
was
doesn't struggle with anything.
perfect.
he is an extraordinary surgeon,
No,
but
he can do with his left hand, he can do with his leg also. So I think Jabin is very good. And yeah, Femto definitely has a role. Incredible videos, Jabin, and lovely discussion, Shreesh. We'll go on to the next,
Thank
since
you.
we're running out of time, we go on to the
Dr.
next
Roshni.
speaker, Dr. Roshni Mohan, and she is currently the vitreoretinal consultant working in Agarwal's. Roshni has had a brilliant career, and she has traversed almost all the top institutions in Tamil Nadu and postgraduate from RIO GOH, and subsequently fellowship from Aravind, PR fellowship from Aravind Madurai, worked as a consultant in Aravind Pondicherry, and she's got a wide publications. She's got a best outgoing student, got the recipient of the ET Selvam gold medal, and she's also very much interested in surgical retina and ROP. Over to Roshni for her talk. Looking forward to talk on management of choroidal rupture, traumatic.
Thank you, sir, for the kind introduction. Thank you, Sujata ma'am, for the opportunity.
Please share your screen.
Yes, sir. I hope the slides are visible.
No, not visible.
Not visible.
Yeah, now it's visible.
Yes, sir. So I would like to start my presentation with a case. This is a case of a 20-year-old male who sustained trauma to his right eye with a bird's beak while driving a vehicle.
Can you put slideshow, please?
Yeah, 1 second. So I would like to start off my presentation with a case. This is a case. No, sir? Okay.
No. Slideshow.
Full screen.
Full screen.
It's okay.
It's not coming?
Not coming, sir.
Okay, go ahead.
Go ahead, no problem. So
at presentation, his best corrected visual acuity was 1/60 in the right eye. Left eye was within normal limits. Fundus examination of the right eye showed multiple concentric choroidal ruptures with subretinal heme at the macula, and an infratemporal commotio was noted. So what did we do? We did a pneumatic displacement with 0.3 cc of 100% C3F8, and patient was advised prone position.
Roshni, your slides aren't moving for us.
Your slides are not moving for
Yeah.
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 Why the slideshow is not coming?
Is it Keynote?
There's a slideshow on top of this thing after design and all, right on top. Maybe that will help you.
Yes.
I come further down. Yeah. No. Yes.
Yes.
No, you're not pressed on the proper.
Is it shown, ma'am? No.
You have to go on top. It's here. It's here. I don't know whether you're able to see it.
Right on top, home insert
Right on top.
design.
Along with the design.
1 second.
Next to home, no, you come along that track. Home, insert, design, transition, animation, slideshow. Can you see that?
No, ma'am, it's not visible. 1 second.
Just escape, close, and open the presentation, probably.
Yeah, this thing is moving. Cursor is moving, but it's not coming on top of the slideshow.
Ma'am, I'll restart this thing. 1 second.
What you do is, Roshni, you open the PowerPoint on your desktop.
Yes,
and
sir.
then share.
Yes, sir.
Keep the PowerPoint open on your desktop and then share.
Yes, sir.
It will come.
Visible, sir?
Visible, but not.
Slides are not moving. There's no slideshow.
Slides are moving now. Yeah.
Okay. Can go to the next slide.
Next slide.
Moving, sir?
No, you have not moved the next slide.
We are.
Yes. Yeah, it's moved.
Yeah, okay. So what did we do? We did a pneumatic displacement with 0.3 cc C3F8 and patient was advised prone positioning for a week. So vision improved to 4/60 at the end of 1 week and 6/9 at the end of 1 month. So,
next slide. You have to pay the slide. It's not moving.
Ma'am, it's moving here. I think there is a lag.
Okay. Okay.
Yeah. This is a fundus photograph. The top one showing the pre-injection OCT with an elevated foveal contour and multiple coma-shaped concentric ruptures on the left side. And the bottom one showing post-injection with a gas bubble in the eye and regressing subretinal heme and subretinal fluid. So now it's a case 2. This shows a 51-year-old female with no prior complaints with a history of trivial trauma in the left eye, followed by defective vision since 1 month. Best corrected visual acuity in the left eye was 20/400. Anterior segment was within normal limits. Fundus examination revealed I'm sorry, ma'am, it's moving very fast or it's not moving at all.
It's okay. You just go ahead.
Can Sai help in this? Sai?
Doctor, I'm Manjula here, doctor.
Manjula, can you just help? Otherwise, we can get a sorted out and then we go on to the next topic and come back here.
Okay,
No
doctor.
point in-
Actually,
yeah.
in the menu slideshow,
I've used the slideshow, ma'am, but it's either moving very fast or it's not moving at all.
I think this version is your PowerPoint version. It's older version, I think. So it is not coming. You just can you share this PDF PPT to me, doctor?
Yeah, sure.
Okay. Roshni, what you do, you share the PPT to Manjula.
Yes, sir.
And let her, because by the time we go on to the next.
Yes, sir. Sure. Okay.
So you can get it ready. Okay.
Send mail to.
Yeah.
Doctor.
You can do that.
Yes, sir. Yes.
Next speaker, you can go.
Yeah.
Next speaker is none other than Dr. Preeti Uday, who is a celebrity oculoplastic surgeon, in my opinion. And I'm really, very proud of Dr. Preeti Uday. Yeah, because she does a lot of very good work. She's a medical director and head of oculoplastics at DRR Hospital. Very, very busy practice along with Uday as well. An oculoplastic consultant, oculoplastic head for also the Agarwal group of hospitals. She's a global examiner for FRCS. She is also a product of the ROGOH and she is very much interested in facial aesthetics, orbital trauma, virtual planning, and navigation surgery. Preeti, all yours.
Thank you so much, sir. Thank
Yeah.
you, Sujata ma'am and sir, for this wonderful opportunity.
Mm.
I think the beauty of trauma is it has brought together all the specialities. After a long time, I'm listening to talks from other specialities. Coming to complex orbital fractures. Now, when we say complex, that means that two or more walls of the orbit are involved. And we can have various combinations of these fractures, like inferomedial, which we see more commonly. You can have zygomatico-maxillary, or you can have the central part, that is naso-orbito-ethmoid fractures, or you can have leaford fractures or combinations with the roof. Now, whenever patient has an acute presentation, when the fracture is complex, usually he will be in a multispecialty hospital because he will have other fractures also or other injuries. And therefore, most of our dear friends, facial surgeons, neurosurgeons, or plastic surgeons, all of whom want to operate on orbit would have finished the primary surgery. And what we normally see is the secondary reconstructions with residual enophthalmos and diplopia. So now the complexity increases when the patient comes to us because now we have malunion, we have non-union, we have bone resorption, we have callus formation, new bone formation, and also greater problem is having soft tissue scarring on top of it. So we don't have very good vascular tissue to cover our reconstructed sites, and also there is fat atrophy. So these situations are really complex, and therefore we need technology in these kind of complex fractures. And what we have been using for many years is 3D printed skull models. These are cheap. They are available for 3 to 4,000 rupees. And you can plan the entire surgery on these models and also explain to the patient very clearly. We can also contour implants on these skull models. Now, virtual planning is the key in complex orbital reconstructions. It has come a long way since the time we started it. Now it is so good that it has now we don't need intraoperative guidance at all, because we can get foolproof planning even before we do the surgery. So the role of intraoperative navigation is almost non-existing now. And virtual planning platforms are available with all the companies which manufacture customized implants. Earlier, we had to rely only on the navigation platforms for that software. And so most of my patients now receive customized implants so that we can really give them a very good cosmetic outcome. So these are the 3D printed skull models wherein the CT scan of the patient is sent to the printing machine and you get the skull model of the patient. Now, when you see this skull model, you will feel that it's just a zygoma fracture. Why can't you just move it and plate it? And what is the complex in this? But now what has happened is this fracture is 2 years old. So there will be some bone resorption, some bone formation. So we won't know exactly where to place the two fragments together. Even if there is a 1 or 2 millimeter error in placing this, in the three-dimensional, when you look at the patient, he will have a gross deformity. So therefore, we need to do the virtual planning in these kind of cases. Also, if you see the skull model, I have done the surgery on the model. That is, I have removed the scalus and pre-contoured the implant on the skull model so that I can use that contoured implant for my surgery. Now, a step ahead is what we do is virtually, we mirror the normal orbit on the abnormal orbit and we get that mirrored skull model. And on that skull model, we pre-contour the implants. And during surgery, when these implants fit well, we know that our reconstruction is all right. So we don't need navigation screen then. So this is how a virtual, so this is all the pre-op planning before we take up the patient in the OR. So this is how we plan virtually. That is, we mirror the normal orbit, that is the left orbit here on the right orbit. So you can see this orange color is the mirrored image. So in the sagittal section, if you see, there is a fracture here of the floor, the bone is down and the mirror is here. So when we place the implant, our implant should match with the mirrored image so that both the sides will be symmetrical. Also, we can insert the implant that we are planning to insert virtually, and we can decide whether this implant will be adequate or we need to customize implants. So here I'm customizing an implant. You sit on the Zoom meeting with the company and you can tell them exactly what is the extent that you need, what is the mesh size, the screws, where are you going to fix. All that can be designed for that particular patient. And then you can use that implant for surgery. So this is how the customized implants look like. You can also reduce the components so that it is easy to insert them. So here I have split it into 3 components. Now this is how a navigation looks like. This is intraoperatively you're getting guidance. So this is like the GPRS in the car. So wherever I am touching during surgery, you can see that I'm touching the canthi here, and you can see that canthus on the screen in all the three axials, coronal as well as reformatted 3D images. Now coming to cases, you can see this young man. So most of these patients are young who have a higher tendency for fibrosis. Also, they've had complex trauma and they've had multiple surgeries before they come to us. So the tendency for fibrosis is very high. So at the beginning itself, we tell these patients that one stage may not be sufficient and you may need multiple stages for us to get the final outcome. So this patient, he has got 3-wall fracture and you can see the orbital volume is enlarged. We have removed the existing plates, redone the fractures and also put a mesh in the floor and the medial wall. And then with the squint correction, you can see enophthalmos also corrected beautifully well. Another patient, he's a model and he came from Panipat. He has a very gross enophthalmos, a very large floor and medial wall fracture with no inferomedial strut. Now here we have designed a PSI for him, that is a customized implant. This is one of the very early implants that we got in India. It was very bulky, look at the size, and it was very difficult to insert this implant, but you can see it is fitting this fractured site very well, and we could reduce his enophthalmos pretty well. But he needed multiple surgeries because his soft tissue kept scarring also. We did the telecanthus repair and also the hard palate graft. But he also has a little bit of ectropion because of anterior lamellar scarring, which we are going to do in subsequent stages. Now, another patient, gross enophthalmos, operated previously. Again, orbital volume is expanded. We have done with navigation, and you can see the beautiful symmetry that you can achieve. Another patient who has an enophthalmos and lagophthalmos, the zygoma is not placed correctly. The floor has not been addressed by the previous surgery, and we did that using navigation. This is how navigation looks like. You can see the eye tracker on the skull of the patient, and we have used a preauricular incision for the arch, and we have reconstructed the entire zygoma and the floor medial wall and also done a squint correction, and this was the final outcome. Another patient, gross telecanthus, ptosis, phthisis, as well as 3-wall fractures. Again, you need to do a virtual planning for these patients. You can get symmetry in the bony orbit, and after that, the soft tissue drapes well on this corrected bony volume. And this, with the prosthesis and ptosis correction, he got a good result. Another patient, he was wearing a prosthesis. He had multiple reconstructions, but the problem was the socket itself has shifted to a downward position. So this is a malunited zygoma. You can see the inferior rim is so much inferior. So no matter what soft tissue correction you do, it's not going to fall in place. We have done a PSI for him in 3 components. And once the bony socket shifts to the normal position, the lid reconstruction will work better. And now with the prosthesis, the eye socket is in the central location. Another patient, very gross enophthalmos, he also had a frontal bone fracture. And we have again done, now for these, when you want to augment the rim, we use polyether ether ketone material to augment this orbital rim. That looks like a bone, but it is radiolucent, so it is not seen on the CT scan. So this is how the virtual planning we have done for him to augment the rim as well as the floor and the medial wall. And this is the intraoperative picture. It looks like bone, but you can see that it gives a very nice correction for the rim. And post-operatively, you won't be able to see that implant because it is radiolucent. And he had very good enophthalmos correction. Now, second stage, we are going to do this temple hollowing by a PSI again, and that will correct his eyebrow contour. Now, another girl who had 4 surgeries in the past and she had still in enophthalmos. So we designed a PSI from a company from US. The implant alone costed her 4.5 lakhs, but you can see post-operatively, finally, we could correct her enophthalmos. Now, this is a very interesting case here. If you see the cheeks are not symmetrical. On the left side, the cheek is outwards, so his horizontal width of the face is enlarged, and that is giving him that deformity. And what has happened is he had a zygoma fracture, and the previous surgeon has just added a rib graft. So overall, the zygoma is out and it is rotated. And to correct that, we need to again, osteotomize the zygoma and excise some amount of the extra bone. Now, how much to excise? For us to know that, again, we do a virtual planning. We get these cutting guides. So we put this guide during surgery, an exact amount of cut then we make. And we also have positional guides to position the bone back in position. And then we reconstruct the floor and medial wall. And you can see now the cheeks are symmetrical for him. We did not do the lower eyelid correction in this stage. And after the lower eyelid correction, he has sent me his picture from home and he is looking pretty nice. Now, this is a young girl who had a rotating fan falling on her, and she had this injury in childhood at the age of 6 years. So her entire one half of the face is hypoplastic. And here she already had multiple surgeries. You can see all the screws there. So what we did is a telecanthus repair and floor and medial wall fracture. And I also redid her scars on the forehead. And she sent me this picture. Look at how confident she looks now. Her enophthalmos is corrected. The right eye is a non-seeing eye because of the old RD, so she has some amount of exotropia. Now, my last case is this lady with a telecanthus, again ptosis, and again gross enophthalmos. She had 4 or 5 surgeries done in PGI as well as in AIMS. And you can see we have redone the telecanthus repair. That is a large defect of the DCR. She had NLD blocks also. And she sent me this whole set of pictures. And you can see that these reconstructions are not only anatomical, but also they help the rehabilitation of the patient socially as well as ensures their psychological well-being. Thank you very much for this wonderful opportunity.
Excellent talk, Preeti. Amazing results. Really hats off to you. Over to Dr. Sendil for the discussion.
Yeah, thank you, madam. Can you hear me, madam?
Yes, yes.
Yeah, thank you, sir. Thank you, Dr. Tammohan and Professor Mohan Rajan for this opportunity. Excellent talk by Preeti as usual. And the whole range of the cases were extremely complex and very well managed. And what I feel is, just 1 minute. Yeah, so just a few points. So like what Dr. Preeti was telling, these cases have already been operated multiple times. So you have to do the planning before the surgery. That's very, very important. Virtual planning is very important. Before you operate, you have to have a proper plan. Sometimes you need to do custom implants. You need to sit with the implantologist and order the implant. And these implants are not cheap, they're extremely expensive. So you need to sit with the company person and need to take the measurements and the size and the shape of the implant, what you want. And more importantly, you have different materials also. Like you said, you have PEEK, you have titanium, you have Medpore, different implants. And these implants, the PSI implants, are not like the regular implants, they're more bulkier. So a surgical technique also should be suited to insert these implants, because you can't insert them to your small normal transconical incisions. You need to make slightly larger incisions. You need to do a canthotomy cantholysis to open up the incision so that you can slide these implants inside. And most importantly, you need to have very good soft tissue cover of these implants, because exposure and extrusions of these implants are not at all uncommon. I've heard it from many senior surgeons who have a lot of experience with these implants. Exposure of these implants and extrusion of the implants is very, very common. If you don't have good soft tissue cover over these implants, they will extrude. And once they extrude or expose, it's very difficult to manage these patients. So you need to, you shouldn't close the tissues over the implants with tension. It should not be under tight tension. You have to have mobilized tissue. They should have good soft tissue cover before you close up the case. So that's one pearl which you have to be very careful. And I think she has covered most of the points very well. These patients usually have NLD obstructions, they have telecanthus, they have multiple other problems. One pearl which I want to tell is it's always better if you can involve your faciomacry surgeon also, because these patients have malunited bones. And sometimes you need to refracture them. You have to make fresh cuts, and so that you mobilize these bones. And doing it through the intraoral approach also gives you a lot of flexibility. You can't do everything through the skin approach. Go through the intraoral, you can have you can make cuts which are again hidden. You don't have fresh scars. So involve your FaceMax colleagues during the planning. Both of you sit together and make a plan. And most of these patients, usually we do it with our faciomacry colleagues. Don't attempt to do it on your own single-handedly if it's a very complex case, because you need to take the help at some point in surgery. And if you can involve all your other specialty people, you usually get very good results like what she has shown. Thank you, Dr. Preeti, for the excellent talk again. Thank you.
Thank you, Sendil.
Thank you. Thank you, Dr. Sendil.
It was brilliant, Preeti.
Thank you, sir.
Fantastic.
Thank you.
Learned a lot.
Over to Dr.
Roshni.
Dr. Roshni, is she ready?
Yes. I have shared my presentation with her.
Manju, can you share?
Yes, doctor, 1 second.
You have to go to third slide, Manju. Third slide. Next one.
Yeah.
Yeah, I'll start from here.
Yes.
So after that bird beak injury, we could see multiple concentric choroidal ruptures with subretinal heme at the macula with infratemporal commotio. So what did we do? We gave him a pneumatic displacement with 0.3 cc 100% C3 F8, and patient was advised prone positioning for a week. At the end of first week, next slide, please. At the end of first week, his vision improved to 4/60, and at the end of 1 month to 6/9. Next slide. Next. So here is the picture. The topmost left corner shows multiple comma-shaped concentric ruptures, choroidal rupture with subretinal heme. So this is the pre-injection OCT showing subretinal heme, altered foveal contour, and fluid in the macula. And post-injection with the next picture shows the gas bubble taken at the end of 2 to 3 weeks. Regressing foveal contour, the fluid seems to have disappeared, and the foveal contour seems to have started to regain its shape, and vision started improving. Next. So next is a case 2. This is a case of a 51-year-old female with no prior complaints, but with history of trivial trauma to the left eye, followed by defective vision in the left eye since 1 month. So the vision in the left eye was 20/400. Anterior segment was within normal limits. Fundus examination, next slide. Fundus examination revealed bilateral angioid streaks, or the brittle Brooks as we call, with circumferential choroidal ruptures at multiple places and subretinal heme at the macula. So the fovea showed subretinal and intraretinal hemorrhage. Next slide. So we went ahead and did an FFA which showed block fluorescence because of the heme with lazy hyperfluorescence in the peripapillary region, which was evident in the late frames. The SDOCT showed a break in the Brooks with overlying intraretinal fluid and exudates suggestive of a membrane, choroidal neovascular membrane. Next slide. Next. So this is a composite picture. The fundus photograph showing heme at the macula, and we can see the angioid streaks extending from the disc in the peripapillary region. The corresponding FFA or the angiograms show multiple places of hyperfluorescence with a break in the Brooks, and a lazy pattern showed in the circle with hyperfluorescence that is increasing in late frames as well. The OCT corresponding OCT also shows presence of a CNVM with overlying hard exudate subretinal fluid. Next. So because of the presence of heme and CNV, we decided to go ahead with pneumatic displacement along with anti-VEGF, and strict prone position was given to the patient. This patient came to us, this is an old patient of ours, came to us during COVID time, so we could not follow up the patient much. So this patient, because she had brittle Brooks or angioid streaks prior, so even a trivial trauma predisposed her to develop a CNVM. So the Brooks membrane breaks are associated with or without involvement of the RP and the choriocapillaris. Next. So I would like to show a case. Here, this is a case of a 25-year-old healthy female patient with a huge subretinal heme at the macula. She also underwent pneumatic displacement with SF6 gas 100%, 0.2 cc, and they demonstrated complete resolution of subretinal heme. Next. So in angioid streaks, we have large evoluted breaks that result in RP atrophy, and we have areas of calcification which represents thickened Brooks membrane, and hence these areas are also fragile. So hence any trivial trauma results in rupture of the inherently fragile Brooks membrane in patients with angioid streaks, especially at the junction of the two, giving an access for the CNV to grow into the subretinal space. Next. So broadly, we classify choroidal ruptures into direct and indirect. Next. So the direct choroidal ruptures are usually located at the site of direct trauma, that is along the ora serrata and at the periphery. Whereas the indirect choroidal ruptures are seen in the posterior pole or at the site of contricule injury, which is most commonly encountered. Next. So the vision depends on the location of the rupture and the degree of hemorrhage. So if there is any subretinal heme, that precludes the underlying choroidal rupture. So we have to wait for the resolution of heme to understand how the extent of the choroidal rupture. However, an angiogram like FA or an ICG can give an exact extent of the choroidal rupture and the degree of the break as well. So why do we need to monitor these choroidal ruptures? Because monitoring for the presence of CNVM is very crucial. Next. So visual prognosis is favorable, but it depends on the location of the choroidal rupture and the degree of the rupture as well. So monitoring for CNV is very crucial because it is the only most important and treatable complication. Usually it happens in the first year of trauma. So longer the length of the rupture and ruptures within the macula, they are more predisposed to CNV formation. Next. Next. So this review article shows us that choroidal ruptures are commonly reported in 5 to 10% of the cases of blunt trauma. So it can happen in the setting of even penetrating or perforating injuries as well. So they are one of the most common causes of defective vision in a patient with ocular trauma. Next. So this CNVM, which is a major complication of choroidal ruptures, they can be treated with observation, pharmacotherapy, surgery, photocoagulation, PDT. This were the methods of treatment in the ester years. But nowadays, the treatment of choice is anti-VEGF. Eyes with poor visual acuity at presentation and presence of macular choroidal rupture and a subretinal heme, they are at higher risk of CNV development. Hence, close follow-up of these patients is mandatory. Next. So pharmacotherapy with intravitreal anti-VEGF is an effective option for the treatment of post-traumatic CNV. So hence early detection, treatment and follow-up can salvage vision in these patients. Next. Next. So this is an article that shows the predictors for the CNV formation and visual outcome. So as I said previously, the mode of injury, the older age of the patient, the presence of the length of the injury and the involvement of macula, they are responsible for the CNVM formation after choroidal rupture. Next. This article shows the pathomechanism of the traumatic indirect choroidal rupture where the countercoup injury leads to break in the outer retina. Rather, the inner retina is preserved, whereas only the outer retina is subject to assault, and hence the choroidal rupture happens. Next. Thank you for the kind attention. Sorry about the slides.
Wonderful, wonderful. Very nice presentation.
Thank you, sir.
Very tough topic.
Dr. Manavi, your discussion.
Thank you, Roshni, for the excellent cases and presentation, notwithstanding the technical errors which are about to happen. So as I think Roshni has very well pointed out, the choroidal rupture is something that we very often see in our clinic. Very often we see this happening in very young children also come to us when they sustain a injury while playing at school accidentally with a ball or a shuttlecock and all. And it's caused by the counter-coup injury wherein the force is transmitted across the ocular walls and it reaches the posterior pole, and hence the posterior pole and the indirect mechanism, which is the most common, is very prone to be traumatized by this, putting the macula and fovea at risk. Very often they tend to even bisect the macula, causing a drop in vision at the time of injury itself, or can be paramacular. And it's very nice. I mean, when after the acute phase has passed off, you will have the commotio retinae or the Berlin's edema passing off, subretinal hemorrhage treated very appropriately, like Roshni has shown us with the pneumatic displacement. And then you notice that the choroidal rupture is actually parafoveal. And heave a sigh of relief that at least the fovea was spared, but that's not the end of the story. These are prone to develop secondary choroidal neovascularization, and hence the patient needs to be kept under follow-up and made aware of the need to come for regular checkups. And these CNVMs can occur at any time over the course of years, but usually most commonly are reported within 1 year of trauma. How badly the fovea is involved can be best detected by an OCT scan. That can show you how the foveal contour or the subfoveal structures are maintained, and that can help a lot in the prognosis once the acute phase or the edema has resolved off. And a long-term follow-up monitoring for the occurrence of a choroidal neovascular membrane is necessary. In the acute phase, for the if there is a submacular bleed, we need to go ahead with pneumatic displacement. And if there's a CNVM occurring, as usual, the treatment would be in the form of anti-VEGF injections. So choroidal ruptures can actually be very varied in their presentation and also in their outcomes. Thank you.
Thank you, Dr. Manavi. I think we have come to the end of this session. I'd like Dr. Mohan to wind up and give a few pearls.
Yeah, I think it's been a really very exciting session on ocular trauma, covering every aspect of ocular trauma. All the topics were really interesting. All the speakers were really brilliant, and all the discussions were also very, very good and appropriate as well. And before I compliment this ocular trauma, I would like to compliment Dr. Sujata and also the Secretary D. Chandrasekhar for putting TNOA on the top gear this year. Okay, seriously amazing activities, and every week they got at least 3 or 4 activities lined up, which is seriously amazing and incredible achievement by the president of the TNOA and the entire team of TNOA, which is a very vibrant team. And hats off to all the speakers today, and starting from the keynote address from Nirmal Frederick, and then Madhuvanti Mohan, and then glaucoma by Archana, and then Mukundan on chemical injuries, Preeti on orbital fractures, and then Roshni on choroidal rupture, and Jebin on subluxated cataracts. And that's all. Now we have covered everything. And it is really an amazing, what you call lineup of speakers. And I learned a lot. And I'm sure that all the delegates who have been logged on to this particular webinar, I'm sure they'll have a good learning experience as well. And thank you very much.
It's available on the TNOA. Mohan, it's
Yeah.
available on the YouTube channel, so people who have not had the opportunity to
Channel and
watch,
people
you can tell them your fellows.
Absolutely. And
They can watch anytime.
yeah. Yes.
Thank you. Thanks.
Thanks a lot.
Thank you.
Thanks a lot. And I think
Good
thank
night
you
and
again for the Numerotech team. Numerotech team, Manju and Sai and the entire team were really been flawless actually. And they've been supporting the TNOA activities, not only TNOA activities, various other activities as well. And the way they do it is really absolutely professional. And thanks a lot for everything. Good night.
Good
Have
night.
a good weekend. Have a good
Thank you.
weekend.
Good night.
Thank you. Good night, everyone. Bye.
Bye. Good night.
Bye-bye.
Manvi, congratulations
Thank you.
again. Yeah.